So the topic for the next deliberation is a case of type 2 diabetes with serum creatinine of 1.8 mg per dl with macroalbuminuria. For this session, I would like to invite on the stage respected moderator, Professor M K Garg sir. Sir is professor and head of the department at Medicine and Endocrinology at AIIMS, Jodhpur. We welcome you, sir. I'd also like to invite the esteemed experts for this session. I would like to invite Dr. Mohan T. Shenoy. Sir is DM Endocrinology and he is a consultant in the Department of Endocrinology at Sri Gokulam Medical College, Trivandrum, Kerala. I'd also like to invite Dr. Saurabh Pokhriyal. Sir is DM Nephrology. He is the director and a senior consultant in the Department of Nephrology at Fortis Hospital, Gurgaon. Welcome you, sir. Further, I'd like to invite Dr. Amit Maan. Sir is DM Nephrology and director and senior consultant in the Department of Nephrology at the Maan Super Speciality Hospital at Rohtak. We welcome you all, and now I'd like to ask sir to please start the session.
Good afternoon, friends and my experts. I bring greetings from the AIIMS Jodhpur. So here I will first tell you the case and then we will discuss some questions to highlight that what are the recent things are happening in this area, adding on to the previous knowledge. So it is a common garden variety of the hypothetical case that we have the 50-year-old male who is diabetic and hypertensive since 11 years. He is a smoker. He is on the oral medication with metformin, glimepiride, telmisartan, 40 mg and atorvastatin. He complains of the bilateral pedal edema and with dyspnea or exertion since last 6 months, and there is no past history of the macrovascular disease. He is a little bit obese. His BP is still high. He is having the edema, and there is no evidence of neuropathy but have the bilateral NPDR, and cardiovascular examination is normal. Looking at the investigation, he has the mild anemia. His fasting PP is uncontrolled. A1C is again uncontrolled. He having the urinary protein is in the macroproteinuric nephrotic range. ACR is very high. Urinary proteins are 4+. RBCs are absent. Urea creatinine are deranged. eGFR calculated by the CKD EPA formula is 45 ml. Albumin is low and his cholesterol and NDL is still high. Chest X-ray, ECG, echo and ultrasonography did not reveal any significant finding. So presently we have the one case who is obese. He is type 2 diabetes, hypertensive. He is having the CKD, stage 3 G3B A3 plus retinopathy. So this is the common garden variety of the case, and if this case comes to the OPD, the first question comes that whether we are dealing with the diabetic kidney disease or non-diabetic kidney disease. So my question first goes to Dr. Mohan that look, we all are the diabetologists, endocrinologists, and often anybody comes, we say diabetic kidney disease, but often than not, it may be a non-diabetic kidney disease. So can you highlight this to the audience?
First of all, let me thank the organizers for giving this opportunity to me. So as seeing this case, usually in our OPD, we always think of renal impairments, and duration of diabetes is also important. So can you just take the next slide, sir? So we can see that when we are defining chronic kidney disease, we are defining it as many causes as per definition. So abnormalities in kidney structure or function which are present for more than 3 months with implications for health. It is a very simple definition which we can tell. And I think as nephrologists are also with us, this is the classifications already accepted in our textbooks, and Harrison has it, and even the latest KidGigo has it. So it's classified based on CGA, that is the cause, then the GFR categories as well as the albuminuria. So you can see in the self-description table that you can have the 2-3 areas seen here. So that is the age is not picked here, so only the cause is there. So GFR is actually picked up with the calculation as per the renal function decline. So the initial value is more than 90 or more, then that is G1, then mildly decreased is the G2. You can see it is 60 or below comes in the G3A. Further on, we can see that the kidney failure is going on, and towards the end, less than 15 is the kidney failure complete stage. So I think in the OPD setup, we are having many formulas for our outpatient department. So you can calculate via the formulas already available, but please make sure that you are using a consistent formula, or that I think we can take next session. So the diabetic kidney disease is defined in both type 1 and type 2 as the presence of persisting severe elevated albuminuria more than 300 milligram per 24 hours, or that is roughly as more than 200 milligram per minute, or albumin creatinine ratio more than 300 milligram per gram, confirmed at least 2 to 3 samples, concurrently diabetic retinopathy or other absent signs of other form of renal disease. So that means presence of retinopathy is one of the things which is considered. So non-proliferative or proliferative, just mentioned, nephropathy with retinopathy is one of the things which actually happens together most often. So we all agree that nephropathy may not be the only thing, in diabetic nephropathy may not be the only thing. There are some non-diabetic kidney conditions like glomerular causes, membranous nephropathy, tubular interstitial causes, as well as vascular causes. And they are defined as, I think coincident can be true DKD as result of diabetes mellitus, or NDKD, that is a non-diabetic kidney disease, or a combination of these. And as I think nephrologists are also here, we will take their view also, because usually we take it only after the renal biopsy, and it is an invasive procedure. I think Saurabh, Dr. Saurabh, can you just highlight?
Basically, as rightly told, that any patient coming, duration is very important. If it is less than 5 years or more than 15 years, if there is active sediments, if there is associated vascular, you are hearing the bruit, or you are doing the ultrasound and you find the renal atherosclerosis, they may the vascular causes, and there are so many other diseases which can occur in this patient, maybe autoimmune disease. So Dr. Pokhriyal will further add to this.
Thank you. So this is strictly from a definition perspective, but as when you see a patient in the outpatient department and you see some degree of proteinuria, so distinguishing between diabetic versus non-diabetic kidney disease, like the points you highlighted, if there's a massive proteinuria which has a sudden onset, if there is significant amount of blood in the urine, or if you have reason to suspect vascular disease or a very rapid deterioration in GFR, you would think in terms of non-diabetic kidney disease. But having said that, a lot of diabetic patients will present with just proteinuria. Like our case here has proteinuria, no RBCs in the urine, has 11 years of diabetes, has NPDR. So you would, by definition say this is diabetic nephropathy. And the standard of care so far has been that when patients present like this, nephrologists will not biopsy them. They will say, this is diabetic nephropathy and we will treat as per diabetic nephropathy. But there have been series where patients have been biopsied even with just bland urine sediments. And surprisingly, nearly 50% of the patients can show evidence of non-diabetic kidney disease along with diabetic kidney disease. So I think that threshold for biopsying a diabetic patient, even in the presence of retinopathy, is now getting lowered.
So what Dr. Pokhriyal is conveying, that we should stop not referring the patient to the nephrologist, and rather than refer every patient to the nephrologist, which person sitting here may not agree, because these are always with the two coins, that it is their side view and it is our side view, but definitely we agree with that. So now we continue with the Dr. Pokhriyal, and as he has just told, how common is the nephrotic range proteinuria and DKD, and what are the other etiology we must think of?
So again, not a straight answer to this, because diabetes is no longer left untreated. And so you don't see patients who've had no treatment for 10-15 years and you could get the exact incidence of nephrotic range proteinuria. Having said that, we broadly follow the rule of 1/3. Roughly 1/3 of diabetic patients, so about 20% of type 1, 40% of type 2, in the long run can develop some degree of proteinuria. Of these, if treated properly, about 1/3 can go back to being normal in their protein excretion. 1/3 of these will then progress to overt proteinuria, which is called macroalbuminuria, but we define as more than ACR of more than 300 milligrams per day. Yeah. And Of these, 1/3 over a period of time will progress to CKD and then ESRD. But this is an oversimplification. With all the interventions that we do now, you would not see a patient follow this typical pathway. So, with the advent of ACE inhibitors or angiotensin receptor blockers and SGLT2 inhibitors now, this is kind of spread out over a much longer period of time. And that's what the aim of therapy is out here.
So, diabetic DKD usually have the pattern of the progression which we have read in the books, but that pattern is getting altered with the current treatment which is available as the glycemic control, as the antihypertensive treatment, as a lifestyle and other therapies also. But as rightly pointed out that in this case, though retinopathy is there, though there is a macroproteinuria, but still other disease should be considered in such cases also. So now I come to the Dr. Amit. Based on the clinical NM finding in this case, which do you think is the DKD or NKD, and how will you further investigate this case? Dr. Amit.
Thank you very much. The presence of retinopathy in this case almost rules in the favor of it is a diabetic disease. But yes, some of the clinical factors in the patient, rapidly onset of proteinuria, rapidly progressive renal failure, and presence of active sediments in the urine are the factor. Even if you have a retinopathy, you must consider, okay, something we may be missing. And to highlight one of the cases, a practical example which I had in one of my clinics, I have been following up one patient of diabetic kidney disease for almost 1 year or now. She came to me with the creatinine of just 2 milligram per deciliter with significant almost 2 grams of proteinuria. She had no sediments in the urine, had retinopathy, severe retinopathy. I labeled her as a diabetic kidney disease and followed her up. In almost 6 months, she went into end-stage renal disease. She came to me after 6 months. She was on regular follow-up. Every 15 or 20 days, she was following me up. I saw her creatinine rising from 2 to 3, 3 to 4, 4 to 5. In spite of everything we missed, and she landed into dialysis. Just before the stage of dialysis, I was thinking what I was missing. I had everything in my hand. So I went ahead and did a biopsy. Should I not label a patient and should I not miss something that the patient doesn't have? We did a biopsy. Fortunately for the patient, or unfortunately, the patient had diabetic kidney disease. Some exceptions are always there. You must think that if the patient is rapidly progressing, in the presence of retinopathy, we should consider other diseases. Presence of non-diabetic kidney disease in concurrent with diabetic kidney disease is still there. It is not there that we may not see a vasculitis in a patient with diabetic disease. ANCA-associated vasculitis or ANA or SLE can overlap. There has been series and studies in various countries and even in India where one of the largest series where 75 patients with diabetic kidney disease were underwent a biopsy, and almost 40% of the patient had a non-diabetic kidney disease. 20 patient had non-diabetic plus diabetic kidney disease, and as a patient had diabetic kidney disease. So one should not go with the dictum that presence of retinopathy is almost mandatory. Yes, it favors, but please open your brains and follow up the patient very closely that you are not missing something.
So Dr. Amit has wisely said that, again, emphasis on the point that as an endocrinologist, we should not be overconfident in dealing with the nephrology case. So every case, if as highlighted Dr. Amit, that rapid progression decline in the GFR definitely should alert your brain that you should not be missing anything. Thank God it came out to be DKD. And we all have seen some exceptional cases occurring before the 5-year phase, rapidly progressing retinopathy, nephropathy, neuropathy, all kind of the things we have seen since 30 years. Everybody sees the exceptions to the rules are there. But definitely as a physician, as an endocrinologist, nephrologist, we must pick those exceptions and do good to the patients. So what he has told again, as he told that how the pathology goes in case of the diabetic nephropathy, that is start with the podocyte injury, then glomerular basement membrane thickening, then meningeal proliferation, then nodular sclerosis, and then diffuse glomerular sclerosis, and they'll end up with the end-stage renal disease and the dreaded complications. So again, same type is there, so I will not go into the detail of this. So what are the newer markers of the nephropathy? I again come to the Dr. Mohan. So it is not that what we have the albumin. We all think albuminuria is sine qua non of the kidney disease, but actually you think as a student, before albumin start coming into urine, there has to be something happening in the glomeruli. It must be a podocyte, it must be a glomerular membrane. So even glomerular membrane and podocyte, if we can detect those cases and if we can intervene, probably we can detect and prevent the kidney disease more efficiently than not detecting. So now the emphasis is coming that how can we detect earlier marker where we can detect that this patient may go into the nephropathy and we can start the treatment and prevent such a dreaded complications. So Dr. Mohan.
Yeah, this is again a good graphical representation of how we can screen when we have newer markers available. So I think in the left side you can see that there are early stage we can have some circulating biomarkers. I think we agree that these things are not available in a commercial aspect, but if you have centers where they do this, you can always check whether they are doing KIM1, TNFR1, TNFR2, then histopathology biomarkers are there. So these are all the things which we can see in the early stage, because before they progress into the heavy load of macroalbumin, we can always pick them up. Histopathologically, we can check the thickening of the glomerular membrane, then the mesangial expansion with matrix deposition. As time goes, clinical biomarkers are more that is EGFR, proteinuria, health. Then again, you can see that histopathology biomarkers are many. So Kimmerschild nodules are also there. So I think you can see that working together, the pathologist also will be helpful. I think with nephrologists in the panel, I think there are some other markers, cystatin C, so many new other markers are coming up. So I think we should think that these things are not very rare to be done. So we should open our books and maybe check latest literature whether these are available or not. But again, pathology has to be very good in your center when we have this.
Okay, just you have mentioned the Dr. Pokhriyal. So now I come back to the Dr. Pokhriyal for his opinion also.
So just to add to this, like KIM1 is kidney injury molecule 1 was actually first discovered for acute kidney injuries, so where ATN happens, acute tubular necrosis. This was actually found to be elevated in certain chronic kidney diseases as well, including diabetic nephropathy. But unfortunately, these are not in widespread use. These are mostly restricted to research settings right now. So from a very practical point of view, as a nephrologist, what we always want from our endocrinologists is, if you have a diabetic patient, screen them regularly for albumin excretion. I think that's the earliest thing we can find. It's the easiest thing to do right now. I mean, you know, even creatinine starts to go up very late. So if we need to handle such conditions, a simple albumin excretion is, I mean, extremely cost effective. And if, you know, you catch albumin excretion early enough, 1/3 of the patients will go back to being normal albuminuric with, you know, ACE-ARB or SGLT2. And that's where we can actually stop the progression of this disease.
So Dr. Pokhriyal rightly told, as an endocrinologist, every year we must screen them for the microalbuminuria, and that is quite easy because now it is a spot urine test by the ACR in the morning. You don't require the time collection of 4 or 24 hours, and that can definitely help you. And once it is found positive, you can repeat after 3 to 6 months. If it is positive 2 to 3 times, definitely you can modify your treatment, which will come later on. Dr. Pokhriyal, there was just some studies was going on that there's a microRNA 21, I think, if I'm not wrong. Excess of that has been even before the podocyte injury. So they are projecting that if we can go to that level, we might detect it much earlier.
So again, what they do in microarrays in these patients is look at urinary biomarkers, so, you know, transcriptomics and proteomics.
Yeah.
But again, like I said, these are not in clinical use at all right now.
Agreed.
It's not been validated for widespread use, but that is going on where you can pick up urinary markers extremely early, even before the albumin excretion goes up. So
Exactly.
when there is the stage of hyperfiltration and there is some tubular hypertrophy because of increased glucose and sodium filtration, there are certain tubular markers which come out which you can detect on microarrays.
So what Dr. Pokhriyal is saying, and what we must remember, that though in my generation and probably sitting here panelist, we have the only microalbumin, but in your generation maybe transcriptomes, proteomics will be available, and you might get the many more markers where you can detect the diabetic kidney disease much earlier, and hope so.
Also, I would like to add one more thing. It is the correct collection of urine specimen which is very important. You please take a history from the patient ki how you have given the sample. Is he running fever? Is he on any antibiotics? Is he under some stress? Has he undergone exercise? And then given a sample, because these are the misleading factors. They will give an increased protein excretion in the urine. Please make sure that the urine correction is correct. Take a menstrual history from a lady. Take a history of fever. Take a history of some medicines. And then only give a sample for the protein.
Well highlighted that what precaution we must take while telling the patient to go for the test, that any fever, UTI, sudden hypertension, CCF, there are so many conditions which may cause the albumin in the urine and which may give the wrong indication to the patients. So now coming back to the Dr. Mohan, I think can you tell that since suppose patient has come to you now, and now we know it is DKD suppose, then what we can do to delay the progression of the disease?
So here again, we should just highlight that newer agents also are there, but the time-tested molecules are basically the AC inhibitors, the aldosterone antagonist, and the ARBs. So this you can see the mechanism of action. This is all theory, but you can see the clinical evidence is there that they delay the progression from normo to microalbuminuria and macroalbuminuria, AC inhibitors. And also you can see they even decrease the risk of mortality and decrease the progression for normotensive patients also to progress to albumin. So the practically will be to check the potassium levels, and you understand that when you are planning pregnancy, we should stop those medicine because they can cause renal artery stenosis in the baby. And also you remember that we should have no benefit in combining them with ARB because they may increase the risk in these conditions. For patients with progression, definitely we have to highlight that mineralocorticoid antagonists also are there. So the first line therapy nowadays I think has been also evolving. So towards the end you can see in that table that ARBs, just previous slide, sir? Yeah. You can see that they actually, ARBs also have this role because they block the binding of angiotensin receptor and inhibit the vasoconstrictive aldosterone action. So that means that again the potential to benefit is also there, but again you should think that these agents are now established, and aldosterone antagonists like spironolactone, then eplerenone, all are there, and even latest drugs finerenone also has come. So remember that these agents are being used for studies, but they were very small and underpowered to detect patient-centered outcome. So which is why we should see the latest KidGigo guidelines.
So basically this is the what we say that in the diabetic nephropathy, one sets in what Dr. Mohan was telling, that lifestyle management is part of the whether kidney nephropathy is there or not there. In the previous lecture we heard we must do the lifestyle if you have the liver damage. I say that you must start, we all must start lifestyle when we don't have the disease. Why we have to wait that we have developed obesity, we develop IGT, we develop diabetes, तब हम exercise करेंगे, तब हम खाना कम खाएंगे. Once you are healthy, you must start doing when you don't have the disease. You don't wait for the disease to have the lifestyle modifications. So, and one more point is very important, that an ACE inhibitor, when the macroalbuminuria is there or albuminuria, you increase the dose till patient tolerates, or you develop the hyperkalemia. Otherwise, you can keep on increasing the dose to the maximum tolerated dose and see the effect on the albumin level. If they fall, well and nice. If they don't fall, you can add on to the other drugs like mineralocorticoid antagonist or other drugs to have the effect. Again, I am coming to Dr. Pokhriyal, I think. How do these agents provide renal benefit and lifestyle again? And patient is having the CVD risk factors, so CKD patients, although the increased risk of the CVD. So, Dr. Pokhriyal.
So how they provide benefit is basically ACE ARB have the same effect, afferent arterial dilatation and relaxation of the efferent arteriole. So what that does is it decreases the intraglomerular pressure. Once the intraglomerular pressure goes down over a period of time, the degree of glomerular sclerosis decreases. So that preserves kidney function. So it's a fairly straightforward effect on glomerular sclerosis. Number two is ACE inhibitors also decrease the blood pressure, ACE ARBs. Coming back to the previous slide, I think you've put there. No, it's the one, yeah. So apart from that, very specific, which we advise our patients is a protein intake, which previously the guidelines were in CKD, if you want a slow progression, go down to about 0.6 grams per kilogram per day of protein, and not more than 50% being provided by proteins of high biological value. But the latest KDIGO guidelines have actually upped it to about 0.8 grams per kilogram per day. We don't tell our patients to stop proteins of plant origin. So dal and all is okay. Animal proteins, especially people who have consumed a lot of non-vegetarian food, there we tell them to get down on the amount of protein that they have. The second thing which we ask patients to do to control their blood pressure is one of the prime drivers of high blood pressure in CKD of whatever origin and also in diabetic kidney disease is salt. So we advise all our patients to go down below 5 grams of salt in their diet per day. For comparison, a typical North Indian diet is about 10 to 15 grams of salt per day per person. So it's about going down to 1/3 of what they normally have. And apart from that, exercise, maintaining a appropriate weight for their age and gender, and avoiding non-steroidal medications.
So Dr. Popokrel has nicely pointed out, and normally when patient as endocrinologist, they develop CKD, dal band kar do, meat band kar do, egg band kar do, doodh band kar do, and you deprive them of the protein rather than supplementing the protein. So what we highlighted that everything can be taken, only quantity becomes the important. So it is not that you wholeheartedly stop everything. And I have seen the patients in my OPDs that somebody outside says, everything he has stopped. There's nothing left to eat because carbohydrate diabetologist has stopped, fat endocrinologist has stopped, protein nephrologist has stopped. So he said that I can't eat anything now in the diet except mineral, vitamins and water. So, in the lighter note, yes, now I'm coming to the Dr. Amit. Yes, because now this is the futuristic view that what are the future things are coming up. So I think Dr. Mohan can take up this and supplemented by each one of you because these are the futuristic things which might be coming in the future.
So this again has been coming in the last year. So we can see here that diabetic kidney disease triggers have been understood as oxidative stress, then metabolic factors, then the hyperglycemic factor. So the advent of SGLT2 inhibitors and GLP-RA address another facet which actually previous drugs never addressed, that is the fat mass. And you can see that they are actually having no hypoglycemia as such. So you can see that triggers like oxidative stress, they cannot be prevented unless we have the direct acting agents. So that's not available. So metabolic markers also, we can see meta-inflammation. Here again cytokine storm also can happen. So these are again cytokine based therapies which are experimental, and maybe CCR2 and CCR5 are not there now. But as Sir told, we may have them in our armamentarium very soon. And again, towards the end, we can see some signaling pathways issue, because once they go into the diabetic pathology, before that you have the signaling pathway. There again, you have some, that is the tyrosine kinase inhibitors. You can just see those names. I think with time, we'll get more and more IMIBs, so selinimab, baricitinib, and you can see barofenib. And you can see pentoxifylline, CTP, and other drugs, they are also acting on the phosphodiesterase level. So ultimately, we can see the available drugs, the diabetic pathology to prevent those, the non-steroidal MRA, which are now available. Finerenone is available. Then ETA antagonist is also there. So this is the way I think the latest publication on advanced kidney that they have already summarized this table.
Dr. Pokhriyal, just 15 seconds comments from you.
So bardoxolone was tried. There was a lot of interest in that it increases GFR. Yeah. But unfortunately, it also increased the blood pressure and protein loss. So that I don't think is being used anymore. Is no longer recommended in diabetic kidney disease. Anyway, it was not allowed.
Agreed.
Pentoxifylline, we have small studies and we have data to show that it does preserve GFR, and it's an easily available drug which has been used for a long time. So I think we'll see more of this coming in. Non-steroidal MRAs, I spoke to Bayer a few days ago, and it's being launched in India. Finrenon it's
Finrenon.
already been licensed, and it's being launched in India in a month or so. So I think that would be an interesting thing to add to angiotensin receptor blockers and SGLT2 inhibitors.
So basically, you know, in the future, keep your eye open. We'll get more and more drugs to sensitize the audience that these are the futuristic drugs which may be there. So coming back to our case, because we have brief time. So our case, they were on the metformin and glimepiride. Metformin is somebody is taking. You can continue up to the GFR of 30, but you don't initiate below the GFR of 45. So we can continue with the metformin, we can add the insulin, we can add the SGLT2 inhibitors, we can add the GLP antagonist. So these are the control. BP control again required, so we have telmisartan might have to increase to the tolerated dose, and we have to add another drug to control the BP. For the atorvastatin, we have to increase the dose to get the lipid control. We have to look for the lifestyle management in our case. So with this, I think we are on the time. So I thank Dr. Pokhriyal, Dr. Mohan and Dr. Amit and the audience for the patient listening. And definitely we will do better and better in the future. Thank you very much.